Hey everybody, it's State Senator Mike Simmons. I want to thank TPAN for hosting this workshop on Xylazine for social service workers, healthcare professionals, and so many others. Xylazine is on the rise in the illegal drug trade and is definitely a cause for concern that I've been keeping my eye on as someone that cares deeply about the public health of our communities and my position as your state senator. I am so grateful that TPAN has taken the lead on sharing this kind of information regarding the drug and how we as community members can help those who may be using this particular drug. Best of luck with this workshop. Stay healthy, everybody. And thank you so much again to TPAN for hosting this event. We'll see you soon back in the district. Bye-bye.
Welcome. My name is Andrew K. Miller. I am the development manager here at TPAN. We are part of the Vivent Health family. We've got a lot of exciting news going on here. We are going to be packing up and leaving this office in 2 weeks for a temporary office for the remainder of this year. We're going to be opening Chicago's first HIV medical home. So we're going over a massive renovation here. And we're going to be able to deliver expanded services to people living with and vulnerable to HIV. Some of these services include full medical services, dental services. We're going to have a food pantry, pharmacy, and more, as well as all of the wonderful mental health and group services that we offer now. We should be offering those expanded services. Thank you. We'll be rolling those out in the next 18 months. And you can learn more about all of this on tpan.com. So thank you for joining Xylazine 101. This is our first community workshop of the year. Our community workshops address local needs and concerns. This one is coming out of overwhelming response. We tackled fentanyl and Narcan many times last year. Now this one, we're just trying to get a better understanding. We are open to ideas and presentation ideas. So if you are a doctor or a speaker or have something that you think would service our community, please reach out to me. Our February workshop will be alternative mental health treatments such as ketamine, psilocybin, massage, and sound. And we'll learn about those treatments, how they work, and then who qualifies as a good candidate to receive those treatments. So our panelist presentations, they're going to be included with the chat available behind me. We'll take questions after each speaker and then have full panel questions at the end of the program. First off, we will hear from Vanessa Cortez. She is a resident with Walgreens, and she is going to help us better understand what Xylazine is. She will have a presentation.
Forgive me, everybody. I'm a Mac user, so honestly, I'm trying to figure out. I feel like I'll be getting consistent.
Okay. Good evening, everyone. Thank you for joining. My name is Vanessa. I'm a pharmacist. I'm currently completing my PGY1 residency with Walgreens in the University of Illinois, Chicago. And we'll get started. Next slide, please. Okay, so I'll be going over some of the basic pharmacological and chemical properties of xylazine, as well as explaining a little bit about why naloxone does not work in a xylazine overdose. Okay, so to begin, xylazine is an FDA-approved medication. It's used in veterinary medicine. It's mostly available in liquid formulations, so in like vials or pre-filled syringes. Can you go back? Thank you. It's not currently categorized as a controlled substance in the United States, but it is harmful to humans. It has been increasingly found in the illegal drug supply in the United States, and it can be found used by itself, but it's mostly in combination with drugs like fentanyl, heroin, or cocaine, or a variety of other drugs. So xylazine was first synthesized in 1962 by Bayer Company, and it was actually intended to be a blood pressure medication, but due to its excessive effects on the central nervous system, it was relabeled to be a veterinary medicine. It is sold legitimately by pharmaceutical companies that sell medications for veterinary use. Some of these companies include Next Gen Animal Health, Midwest Veterinary Supply, Animal Health International, and these are just a few of the companies, but there are many more available and out there. However, unfortunately, it is also illegally sold on the internet and on the street, and there are suppliers who are selling it for like somewhere between like $6 to $20 for a kilogram. And so when drug traffickers get a hold of this medication for so cheap, they're lacing it with their drug mixes in like heroin or fentanyl or whatever they're using. So that way they can use like less of their supply of the drugs they're mixing it with. Okay, so xylazine is a phenothiazine compound and it exists in a hydrochloride form. And that's just a fancy way of saying that it looks like that structure. We don't know much about it chemically in humans. However, we do know that it's an alpha-2 adrenergic agonist. And what this means is that when the drug activates the alpha-2 receptors that are located in our body, it decreases the release of things like norepinephrine and dopamine, which causes our bodies to feel sedated and could produce analgesia or pain relief and just like a calming effect and like muscle relaxation. And these effects are seen within minutes as soon as you ingest the drug. Okay, so there are limited studies that are in humans, and these are mostly from when the drug was being studied as a blood pressure medication that we have data that shows that is toxic to humans, mostly because of the effect that it has on these alpha adrenergic receptors on the central nervous system. So it causes things like drowsiness, a decrease in heart rate, decrease in blood pressure, and it slows the respiration. And the signs and symptoms that we see with an overdose are similar to the ones that we see in opioid overdoses, such as slowing the heart rate, blurry vision, disorientation, slowed breathing, but it could also cause comas or seizures. Okay, so I just wanted to briefly go over the reason why Narcan or naloxone does not work in a xylazine overdose. So the purpose of Narcan is to reverse the effects of an opioid overdose. And the way that this works is that the Narcan binds to mu opioid receptors that are located within our brain. And the Narcan actually has a higher affinity or attraction to these opioid receptors. So it kind of just like kicks out the actual opioid. So the real opioid does not bind. And when the naloxone binds to the receptors in our brain, it reverses the effects of these opioids and then restores the patient's or the person's breathing. And the reason that it will not work with xylazine is because xylazine is not an opioid. So like I mentioned, it's an alpha adrenergic agonist. However, since there are lacing other drugs like cocaine or fentanyl with the xylazine, it is recommended that they still use the Narcan just so that it can reverse the effects of those other opioids, but it won't reverse the actual effects of the xylazine. And that is all I have. Thank you for listening.
Thank you so much. Our next up, we have Michael Huyck. DNP, FNP at UIC Mile Square Substance Abuse Disorder Integrated Care Team, who's going to talk to us a little bit about the medical side of this issue.
Hey, everybody. I'm Mike. I'm also from the University of Illinois, and I work at the Mile Square Health Center. So just a little bit about my background is I work in an integrative substance use disorder treatment program, meaning that we provide a full scope of addiction treatment, methadone, buprenorphine, naltrexone for a variety of disorders, as well as primary care, infectious disease treatment, behavioral health care, all in the same place. So it's a really cool model of care, and that's why I work there, because they let me do cool stuff like that. But a little bit about my background is like I have a very strong foundation in harm reduction. I worked in a syringe exchange for 4 years as a nursing student. I opened up a community wound care program in the syringe exchange. I work with Huyck. So a lot of people here are probably very familiar with that organization as well. And so today, we're going to talk about exactly like how this drug is affecting people who are using it. Next slide, please. So just like one of the biggest complications aside from dying from a xylazine overdose is having these really bad cutaneous complications of injecting this drug. And just across the board, anyone who injects drugs has a very large prevalence or incidence of wounds. Okay, so when I was working at the syringe exchange, and even to this day, and I still do work with them, about 20% of the people who are coming into a syringe exchange have a wound at any given time. So there's just a very heavy burden on people who inject drugs as far as wounds, and xylazine is like making that burden much worse. Okay, and so not all wounds are infected. They could be scary. They could be big. We don't want to just throw antibiotics at them. They just need careful, care. We treat them like a baby and take care of them and heal them. Next slide, please. So, what are people injecting? A lot of things: heroin, pharmaceuticals, xylazine, fentanyl, cocaine, methamphetamine, or combinations of any one of these drugs. Next slide, please. Where are people injecting drugs? Anywhere you can find a vein. And so anywhere somebody injects a drug, they have potential of developing a wound, especially if that drug is tainted with xylazine. So, some of the more dangerous places that people are injecting would be like in the inguinal region, in the neck and everything. Of course, this can lead to blood clots within the circulation. I've seen traumatic amputations of upper and lower extremities related to this. I've seen people die. Not necessarily from overdose, but just from, the sequelae of injection. Next slide. And so, when we think about these adulterants in the drug supply, Taylor's not here yet. Taylor's magnificent. Drug trackers are this nation's true heroes. Most folks in our government are not necessarily checking the drug supply for contaminants. And so our clients really can tell us when something's up. And so this is not a client that I saw for xylazine, but this was back when crocodile was a thing in 2018 briefly, which is a synthetic opioid that was first kind of cooked up in rural Russia that made its way here for a little bit. But something was really off. This person told me hey, when I cooked up this, it looked completely different. When I injected it, it felt different. There's something wrong with the supply. And this happened to be in Elgin, Illinois at the time. Next slide. So we should always listen to people. Though a lot of times we'll tell you what's up before we even know it. And so, how do people end up with wounds from injecting? And there's a lot of different ways. So, there could be contaminants within the drug supply. We have strep, staph bacteria, resident bacteria on our skin. If it's not cleaned properly, it can be introduced. People can end up with abscesses and everything, and then self-treat them. Those can end up as a wound. People sharing injection equipment, a lot of these things. Contaminants that are in the substance like xylazine. Next slide. And so also the pH of heroin itself is very low. It could be anywhere from 3 to 5. And so, think of what would happen if you injected vinegar and it got under your skin, you might end up with a wound. So if you are not getting into a vein and diluting your drug and you're extravasating that under your skin, whether there's xylazine or not, you could potentially end up with a wound, but xylazine makes it much more probable that you will have a wound. And then, also not just xylazine and heroin and fentanyl, it's just any drug that's injected. Some of the worst wounds I've ever seen have been from intravenous administration of methamphetamine, which causes vasoconstriction, can cut off blood supply. So just injecting in general, really high risk for wounds. Next slide, please. And so, some of the things we want to be checking with people if we are seeing people who inject drugs and they have wounds, making sure they're cleaning it. Because some people don't know they're supposed to clean their skin before they inject. We have to teach this good injection hygiene and everything. The more people are injecting multiple times a day, multiple, increases in your chance of developing a wound. So if we can get people to decrease the amount of times they're injecting, we could decrease their risk of developing a wound. Also, injecting into a wound, this is something that I've explored out in the community, is that a lot of times folks, after decades of injection, they'll run out of venous access. And so there's a lot of folks who, not a lot, but half of the people I run into who have wounds, who are actually injecting into their wounds as a route of drug delivery. It's a very good vascular supply in the healing wound bed. And so there's really quick drug absorption. It's just a testament to how difficult addiction is for people, what folks will resort to stay healthy, stay good, not in withdrawal. Next slide. And so this is just an example of a client from a study that was injecting into their wound. So it's really important to ask people about that. Skin popping, intramuscular injection, injecting in your muscles, all these increase your chances of developing a wound if you're not getting it into a vein. Next slide. And so kind of like xylazine, Tranq, is what they're calling it on the street. It's a downer for everyone who uses it and for us healthcare professionals. It's been in Puerto Rico. That's where it was first kind of noticed in the early 2000s. I remember as a teenager at that time, watching a Dateline episode, and it was titled the zombie heroin of Puerto Rico or something, or Channel 1 at the time. And so it's been around for a while. And that was the video short but I can never find the episode. I looked for it. And so, yeah, it's an anesthetic. It puts you down. And so when it gets in the heroin supply, people don't really notice a difference because they both put you down, right? And so it's been around since the 2000s. And then it kind of made its way up to the United States. We first noticed it in 2013 in Philadelphia. And then it was first, I think, identified in our drug supply here in Chicago, around 2018 or 2019. But that's just when we started looking for it. Who knows? It could have been here all along, right? Who knows? Next slide. And so just kind of like I said, our clients know best. And so this is a client who I'm seeing who has wounds, who tested positive for xylazine, and this client insisted that there's something different about this drug supply, that even with the most meticulous injection technique and getting it into a vein every time and cleaning their skin, just the mere act of pulling the syringe out and whatever residue is left on the bevel of that needle has been enough to cause these very small pin-sized ulcers, which then kind of cascade into a wound. And so, why does xylazine cause wounds? We don't actually know because we haven't studied it. So there's just a hypothesis of why xylazine causes wounds in people. And so, kind of like Dr. Cortez was talking about, it's an alpha-2 central agonist, but we also have alpha-1 receptors, or peripheral receptors in our skin. And that kind of, when we agonize those and we kind of tickle those receptors, it causes vasoconstriction. So the hypothesis is that when this is being injected locally, it's cutting off blood flow at the very at the very top layers of the skin and everything. And so then it's causing the tissue to die, skin necrosis and everything. But there has also been wounds reported in people who are using xylazine that are not injecting. There's a few case studies of this. It's not very widely reported. Now that I'm thinking of it, I've had a few clients with, I call them immaculate wounds. I could not figure out how they were getting them. They weren't injecting. This is back in 2019, 2020. Maybe it was xylazine, but they have been reported. So you can't pull that out of the list of possibilities. Go back one more slide. Okay, this is kind of this is a client that I was taking care of. They had a xylazine wound. They're also injecting their wounds, but yeah, it's even if you're not injecting, there's the potential for that to happen. Next slide. And so what do we do for folks who are injecting heroin, mixtures of heroin and xylazine, they're kind of ubiquitous for me at this point. Make sure, good injection, hygiene, harm reduction, Chicago Recovery Alliance, they're in this area, COI, making sure they had access to clean injection equipment. Xylazine test strips at most of those harm reduction facilities, you can get those. They're kind of distributed by CDPH, Chicago Department of Public Health. And then what do I do at my practice? I have like a small formulary, like of wound care supplies, like 10 items. I have gauze, I have ABD, like absorptive pads. I have Vaseline, barrier cream, hydrogel, medical honey, everything that's like really cheap and it costs under $1 because I'm constantly like asking for little grants so I could just give people free supplies so they can care for their wounds. Because a lot of these clients, like they will take care of themselves. You just have to teach them how to do it and get them the right equipment to do that. So folks are not stuffing like McDonald's napkins into their wounds and then coming to my clinic and I have to debride them. It's very difficult and painful. But like the most important thing we could do to prevent this is just to get people into treatment. Like a lot of times, like this has been a major push for folks who have kind of been thinking about getting the treatment. Like they end up with a wound. They're like, I do not want to live like this any longer. Like this is the worst, to have an addiction, to experience this. This is the worst thing I've ever experienced in my life, and so I wish that wasn't the impetus. Like this is a terrible thing for people. And so really just trying to support people, get them wound care supplies, try to get them to cut down and try to get them into treatment so they can stop injecting. Like that's what's really going to stop the wounds. Next slide. And so, if you know somebody that has a wound, it has an addiction issue and they want to get some treatment for it, this is our access line. So we have a social worker that staffs that line. Depending what clients want, if they have opioid use disorder, they want to get methadone treatment. We have that. We have a family guidance on site, and so I can prescribe methadone to them. Like I said, I have a small wound care formulary. We have infectious disease professionals that work with us, and so feel free to send them my way. Send them to see Mike the nurse. So that's all I got.
All right, I have some questions specifically for you. Terminology, in both your opinions, is this considered an overdose, an exposure, or a poisoning?
My professional opinion is like, no, like a wound related to xylazine injection is not like an overdose. I would attribute an overdose to like somebody losing consciousness. Poisoning, would like, it could be kind of broadly considered a poisoning because there would be like an end effect. Usually poisoning is an end effect on some organ system. And so the skin is an organ. So I more look at this like as a toxic side effect of the administration of the drug.
Are there signs of early exposure that people who come in contact with injection users that they can look for? Are there early signs? We're going to have a full service health clinic. When do we know to kick them down the road over to medical professionals?
So one of the early signs that you might notice with somebody who's injecting is kind of one of the signs that's associated with what we would call a missed hit, where maybe somebody's not getting it directly in the vein. They extravasate some of that the drug they're injecting under the skin, and it kind of becomes inflamed. It becomes warm, red to the touch. Now, that doesn't mean that they're going to get a wound, but if that then people notice that the skin is turning purple, turning black, that's a sign of the tissue dying, and probably a good indication that once that tissue dies, it'll then slough off. And so any type of like abnormal discoloration that a client who injects notices at the injection site, such as like purple or black skin, those are really, really bad things. Like those are like signs that they're going to develop a wound. Now, you can't really treat a wound until it's there. And now a lot of these folks don't need to necessarily be referred to wound care specialists. I'm not a wound care specialist. I play one on TV. I'm a registered nurse. I worked in a hospital for 10 years. I covered a wound care service. I've worked every specialty. So nurses, like, we know wounds. So if you're going to have a full service health center, having a nurse practitioner or an RN on staff, like that's going to be your care go-to. And bring me over. I'll talk with them and help them train them up. So
A couple more questions. Are there prescription drugs that xylazine interacts with that make people more susceptible? We're an HIV service agency. Is there anything we should be, or is xylazine just going to hit everybody just as bad as the other?
I'm not a pharmacist, Dr.
Well, is that one, it hasn't really been studied that much in humans, like its exposure, its effects. So to say that like there would have to be clinical trials of the medication and its interaction with other medications. And I didn't see anything that it like would interact with more. I mean, like there are drugs that are more sedating that are prescription drugs, like your benzodiazepines, your gabapentin, like your sleeping drugs, your trazodone. Those drugs are probably going to cause more sedation and like more respiratory depression when given with xylazine. But in terms of interactions, like with other like HIV medications or like your blood pressure medications, your cholesterol medications, we don't have that information. But we can say that with like the more sedating drugs, like it is going to be cause like that more like that additive effect of like the extra sedation and extra respiratory depression.
Request for research. Yeah.
Great. All right. We switch over to Taylor's presentation. I'd like to welcome now. We have Taylor Wood, drug checking technician from Chicago Recovery Alliance, who's going to supply us with some more information on testing and other science. Thank you.
Should I stand?
Oh, however.
You need a stick, we got a stick for you.
So, drug checking for xylazine. This is actually what it typically looks like if you get it in a veterinary sort of setting. We've experimented with that with reagents to see if it any use. Didn't. And then here's a dope sample. We quickly call a lot of the opioid samples dope because they're polysubstance drugs. They contain a variety of different opiates or opioids, as well as xylazine at times, benzodiazepines. So it's, dope is the word that I will kind of use for this. Next slide, please. So our drug checking program has been running since 2019. We started a pilot in early April. And then even prior to that, we had these awful devices called the HPMS. It was like a high pressure mass spec garbage. It's the kind of device that authorities use on location to give them a quick incarceration. But there's the amount of false positives, false negatives with it. It just wasn't good. So then we evolved to we do community-based drug checking. This is important. We're not trying to get anybody in trouble. We're trying to enable people to do what's best for them. And if someone has, a variety of different accesses to substances, utilizing drug checking enables them to find out which vendor has the best wares for them. Just flat out. The government, no one else is doing, standardized or trying to create a safe supply. So, we're going to utilize the free market, and based off of how people can use drug checking, it will enable, I think, a safety net, so to speak. Next slide, please. So, xylazine, much like fentanyl, we're beginning to see another hypervigilance where we're very focused on it, but without really, I think, getting down to the, I guess I'll back up. If you're looking for xylazine and ketamine, MDMA, cocaine, methamphetamine, you are rarely going to find it. Specifically here in Illinois, we find through all the samples that we've looked at our lab, 10% have been positive for xylazine. But if I take away, all of the non-opioid samples, we end up looking at about 20% positivity rate. Then this is with GCMS, this is with the immunoassay testing strips. So what that means is about 1 in 5 bags will contain xylazine. But, you know, aside from maybe the one ketamine sample that had xylazine in it from New York, we haven't seen it here. In the past few months, I've examined over 100 ketamine samples. It's just been ketamine with, you know, likewise buffs and cuts, but no xylazine. Next slide. So mentioning GCMS, we have a partnership with Drugs Data as well as CFSRE. This enables us to send out samples that are that still, you know, we have questions on. And this is mainly because the immunoassays can just provide, you know, the presence of, a positive presence of, within reason. There are false positives, but the FTIR that we utilize can only, you know, anything below 5%, it might be missed. So there are samples where a lot of the data that we get actually comes from what our third-party lab acquires. And then we dictate which samples to send out based off of kind of experience reports and similar anecdotal experiences. But as we can see here, these are samples from September of 2022 to August of 2023. The sample pool of that is 106 samples for opioids. This is essentially the percentage of what we found in all of those opioid samples. Diphenhydramine or Benadryl, very common in the Illinois supply. Occasionally see trace amounts of cocaine as well as lidocaine, tramadol, and morphine. Heroin and 6-monoacetylmorphine we do see as well. As you can see, fentanyl's at 80%. This isn't a surprise to anyone. There's also some presence of 4-fluorophenol, but the main one, xylazine here, is at a 21.7%. Also worth mentioning metronidazine and Seroquel, but we will be focusing on xylazine today. Now the next slide is going to look at the results from this most recent September to this December. And as we can see, xylazine is still at 22%. This is granted just out of an 18 sample pool count, but we can kind of see some of how the trends have evolved, at least in the past 4 months. We still have some presence of Seroquel. Thankfully, no nitazines have popped yet, but xylazine very consistently at about 20% of our supply. And honestly, that's been so maybe since 2021. Next slide, please. Those at risk, some pretty pictures. I would say anybody who's trying to acquire an opioid or opiate outside of a pharmacy, even if they're acquiring it from a friend who said they got it from a pharmacy, I would say those individuals are potentially at risk for exposure to xylazine. Outside of that, I believe the risk is very minimal. We have, we have seen xylazine within crack cocaine here, and that's because it was likely lumped in with the fentanyl that was also present, but that is more of an outlier. Next slide, please. So to quickly, I've mentioned FTIR a lot, so I just want to dive into that really quick. It's stands for Fourier Transform Infrared Spectroscopy. Essentially uses an infrared laser. It shoots through the sample. Through that, we're able to match it to a library and database. The advantages of using this, it's really portable. It's about no bigger than this. It requires training, but once someone's trained up on that, they can pass that training on to the next individual. Many of the files that are saved from it, we can save those and send them out so other people can be trained on and reanalyze. But the big proponent of this is we're able to identify cuts, buffs, like lactose, mannitol, even microcrystalline cellulose, something that GCMS can't ascertain. And people who are using mannitol in a certain way might want to be knowledgeable of that. So having an FTIR on hand is extremely beneficial. Also, the libraries can be updated over time. So if there's a new substance that hits the market, we can send that out to a lab. Someone can generate a spectra, and then we can operate from that to further analyze it moving forward. Next slide, please. Some drawbacks. If we don't yet have that library, we won't see it. We will be able to identify on the spectra an area that has yet to be analyzed, but we just won't be able to tell the individual what that is. Also no cannabis, no shrooms. We can't test organic material. This is just for inorganics, crystals, powders, some liquids like GHB, GBL, 1,4-BO we can test. Also rough quantification versus an actual quantification. Sometimes that's frustrating because people really, if you're working with fentanyl, you need a very specific percentage range, and that takes a lot of training to get to. Next slide, please. How we collect our samples is kind of roundabout. We have these forms that anyone can fill out. I believe in anonymous drug checking, so regardless of the age, sex, ethnicity, all of that identifying information, like I don't really ask for that. So if someone wants to come into my office, give me a drug, I'll check it for them right there. I'll tell them what it is. What's important to me was knowing what it was sold to them as, or what they think it is, as well as the date that they just acquired it. So I can kind of keep a note of when these things were active on the ground, as well as the zip code. Zip code, though, I usually, if it's blank, I just take the zip code of where it was collected. There's no reason to collect zip codes of people's houses. That's ridiculous. We also take experience report. Very, very important. Because like the samples that we sent off to GCMS earlier, a lot of those that I send off, I utilize the experience report to dictate if this is something that's questionable or problematic. We have drop boxes with COIP on their west side office. We also have a drop box at their south side. We have a drop box at ours. We also have drop boxes on our vans. At the moment, we only have staffing to do drug checking at our west side warehouse. But hopefully this year we will also add a location at our south side, as well as a more mobile checking. Next slide, please. So once we get the sample, we'll take it, we'll put it onto the FTIR. We then analyze our libraries to make sure that the correct ones are selected for this process. From there, we put it through its little algorithmic workings. Here, what we end up seeing, the first thing that we end up seeing is a red line, and that's the spectra that we gather from the plate here. And then the blue is going to be one of the spectrum from the libraries that we have. And each one of these has, 200 entries, 2,000 entries. So we have a variety of different samples that we can look into. Next slide, please. From there, as the FTIR is also analyzing, we run the immunoassay test strips, we run xylazine, we run fentanyl, we run benzodiazepine. This is important because of the threshold detection limitation. We need to make sure that we're not missing xylazine or benzodiazepine, which we can with the FTIR, as well as fentanyl. And then anything that's questionable, problematic, send it out to drugs data or CFSRE. And then we hand the substance back to the individual, and they can go about their day using that information. Next slide, please. And just one of the final slides. This is really what I want to show you. This is where xylazine lives. This is actually on the street where you'll find xylazine and drug samples. These are dope samples. These are random powders. In just this one sample alone, we had fentanyl, gabapentin, 4-fluoropentanol, acetylfentanyl, phenethylphorine PP, 6-monoacetylmorphine, heroin, 4-NPP, 4-eth-phenethylphorine PP, 6-acetylcodeine, ethylphorine PP, lidocaine, and propionyl 4-fentanyl, xylazine, mannitol. So when we're really talking about people using dope, it's much more than just fentanyl. It's much more than just xylazine, although these things play a major part in it. I think the next slide just shows off some of our hours, how you can get a hold of us, our drop-in hours for the West Side Warehouse. We'll find myself or Sean or David. Also our van timetable, where you can find all of our van locations throughout Chicago. And then the next slide should just be some of our examples of our testing kits that are available. Benzo kits, xylazine kits, and our fentanyl test kits. That's it.
Do you have some questions? First of all, thank you all for being here. So a few questions. Why the heck was this made? So it was originally for veterinarian use. Is it still being used? Is it still being created, or is everything we're seeing being is a synthetic counterfeit?
It's still being made. I think it's still used in some veterinary settings. I know personally my vet has actually pulled it because of everything that's occurred with it. So there are some health centers that are removing it and switching to clonidine or other like substances, but I wouldn't say that there are any counterfeits out there yet in the way that we see other things.
And as far as Narcan goes, if someone, they're suspecting someone's having an issue, it is still recommended to use the Narcan to counteract the opioid to release some of the pressure so the body can deal with it. Just asking for a little bit of clarity on that. So it is follow the fentanyl regimen for overdose treatment that we've been training. Again, for anyone out there, if you need supplies, fentanyl and Narcan training, reach out to me. We have Alex in our prevention department who can also help. And then quantity, how much needs to be in someone's drug supply to be fatal? Is it as minimal as we're led to believe? Or we just don't know?
That's a really tricky one because it all comes down to each individual's tolerance. And also the mixture of all the other substances in that bag. Like if someone is using, like someone would be overdosing from the respiratory depression of the fentanyl or the other, like maybe a nitazine present, and the xylazine is going to assist with that. But the xylazine is kind of like a potentiator of those opioids and opiates. So I think if you just took xylazine on its own, you might have an experience, but it wouldn't be, I think is how we would define a standard like overdose through opiates.
I think it's like one of the reasons why like xylazine has been so successful in veterinary medicine is in its recommended dose, it doesn't have the same potential to reduce, it cause respiratory depression, not as much as opioids, that is, but and kind of like Taylor and man, I just want Taylor to talk all day. This is so cool. It's look at all the samples that Taylor has. It's just varying quantities of xylazine. How are you gonna know what's fatal? It's dose dependent. Everybody's tolerance is different, like Taylor said. And how are you gonna know how much you're getting in your bag? It's hard to tell.
Clearly comes with a lot of other risks just outside of infection and all that. Absolutely.
All right, that was the end. Anyone else has questions online? And I'm sorry, I didn't pull with people. Does anybody in the room have any questions? All right, again, if you have any questions, or if you didn't receive these presentations, you can reach out to me. It's andrew.miller@vivent.org. If you'd like to support us, there is an automatic $10 tip jar in the back of the room. You can donate at tpan.com/donate. Or if you have an idea for a presentation or a panel, even if it's yoga or walking your dog, we're looking for some things that aren't always so heavy-handed that the community is concerned with. But that is it for us. And thank you very much for being here. Thank you.